I have been practicing medicine for about a year, so you know I look very young, right? Is that correct, Joanna?
Absolutely.
Absolutely.
You made me look 16.
Okay, maybe 17. So I work internationally with the Androgen Excess Society, and we are trying to figure out the root cause for this disorder, and unfortunately it causes a lot of problems, cosmetically, metabolically, infertility, and that's what we're going to go over today. So what is polycystic ovarian syndrome? Okay, so PCOS, or some people call it PCOS. This is a hard one for me to see. I don't like turning around here, so I'm going to move all the way here. And
That will click on your laptop work.
on the laptop here?
Right there on the side.
Yes, okay, perfect. So as you described, this PCOS, or polycystic ovarian syndrome, or PCOS, is this multiple, can you turn the lights down for me? This is what an ovary looks like on ultrasound. This is a woman's bowel here, and there's multiple little cystic-like structures. So that's poly or multifollicular appearing looking ovaries. Although the tough part about this is that 25% of normal functioning reproductive age women have ovaries that look like this. So that doesn't cause somebody or say somebody has the syndrome of PCOS. They just have polycystic appearing ovaries. It's the syndrome that manifests itself like this. So probably about 50 to 55% of women are overweight, obese, or morbidly obese. But that means the majority, or not a majority, but 45% of women are lean, and they can have the syndrome as well. There are what we define as androgen excess. And so there's some extreme forms. And if you actually open up your packet here, for those people here, and actually for you as a esthetician, if you're still doing that, I find it useful if you look at some of this, not so much this here, but this stuff here. So this right here you can throw darts at. Okay, that's a picture of me. And then there's some background information, fact sheets about PCOS. And I always like to tell patients that tracking your weight and tracking your blood pressure as part of that metabolic syndrome is really very, very important. And this is what we call a Fermin-Galloway score. So it's a nice non-invasive way. It was first described in the 1960s. And there's 9 key element spots here. And if you have a score more than 8, that's defined as excess androgens here. Okay, and that's a clinical manifestation of the PCOS syndrome. And then there's also there's a spot down here there's an internet resource. I forget who said that they were on the internet. And there's support groups for PCOS. And I actually am running a clinical trial on PCOS that I'll tell you about when we get done. So anyway, that starts off with PCOS as a hyperandrogenic state. So women have polycystic appearing ovaries. They have clinical signs of androgen excess, and oftentimes have irregular menstrual cycles. It's unpredictable. Okay? However, there's variants of that. Some women have normal cycles, but they have excess hair. Some women have PCO appearing ovaries, have irregular cycles, but have no signs of androgen excess. So actually Scandinavian women, Asian women, they have less hair follicles like on their face, on their chest, that they may not clinically express signs of androgen excess. So Eastern European, Southern Mediterranean tend to exhibit more signs of the clinical androgens, or hair, excess hair. The tough part about PCOS is its diagnosis of exclusion. Diagnosis of exclusion. So just because somebody has PCO appearing ovaries doesn't mean that they have this disorder, and that's what I'm going to go through with you. So it is the holy grail of reproductive endocrinology. So we still don't know the exact mechanism. We don't know if it's genetic. We haven't been able to figure it out. But we do have some understanding of it. But of all the diseases, particularly in my line of work, we've been able to figure out a lot of stuff, like having babies, doing in vitro fertilization, but we still haven't been able to figure out why this occurs. So I love history. So it was actually, PCOS was originally described in 1721. And it's very fascinating. It kept finding itself in the literature in 1844. They talked about tough, hardened ovaries so that the toughness, people couldn't ovulate. So therefore, that's why they had irregular cycles. And then what's the twist of irony is that in 1920, they actually started talking about not only excess hair and virilization, but also glucose abnormalities. So little did we know that it's actually today is a large part of our understanding that even in the 1920s they described that. And it's also evolved, again, our lack of understanding, God bless you, is that it actually started off as an anatomic abnormality. So in 1935, you may have read this somewhere, they called it Stein-Leventhal, and that was originally reported in the literature. But it was an anatomic disorder. They saw these big, fat, juicy ovaries that had these multiple cystic appearances to it, and it was a thick, tough outer covering. So they defined it as an anatomic abnormality. And what Stein-Leventhal actually did is they thought, well, these women aren't ovulating. They took a wedge resection of the ovary. They just wedged it, and then people started ovulating again. So they just assumed that it was an anatomic abnormality. Well, it wasn't until the 1960s that we started running all these labs, and we realized that it was actually an endocrine abnormality. And the endocrine abnormality is that there's all of these high LH, or these high circulating androgens, like testosterone. So we realized that it's really an endocrine abnormality that's causing women not to ovulate. It really wasn't an anatomic problem. And then in the 80s, we started realizing that that there was not only high androgen levels, but there was what we call insulin resistance and this dark patchy scales in here for women that have excess amounts or really bad polycystic ovarian syndrome. It's called acanthosis nigricans, which is a sign of insulin resistance or glucose intolerance. Now, not everybody has that. This is severe forms of it. And then it wasn't until 2000 that we defined it as what's called a metabolic disorder. So this is the metabolic disorder where you have glucose intolerance, you're overweight, you have abnormal lipids, you have hypertension, you have fibrin abnormalities, and all of this was leading to the syndrome X, and it led to atherosclerosis and hypertension, diabetes, and cardiovascular disease. But we don't see that in young women like you. The metabolic syndrome is typically seen in women that are 50s and their 60s. And that's why this PCOS, I think you may have mentioned that, is that PCOS is not metabolic syndrome. It's a cousin of it, because oftentimes what happens is that women with PCOS can have hypertension, but we're not sure if it's the hypertension's because some women are overweight, or that some women have insulin resistance, but they may be lean, but they really aren't part of this. They're a distant cousin of it that may be associated with metabolic syndrome. So I don't know if that makes that a little bit clearer or more nebulous, but let's talk about the etiology is the cause or the pathology related to this. And if you start with the ovary, all those follicles, the juicy looking ovary with those multiple little follicles, what happens is that the brain causes a woman to recruit one of those small little follicles you saw on the ultrasound. And so there's all these cells in here that convert cholesterol to androgens, and then the androgens are converted to estrogens, and that's what recruits your lead follicle for the month. But what happens is that there's probably some block in an enzyme here that can't allow the conversion of androgens to estrogens. And what happens is that it leads to an increased amounts of that. So that ends up going back to the brain, or we're not sure if it's the brain that causes, that stimulates the ovary to make extra androgens. But then what further happens is that you don't recruit eggs because there's decreased amounts of a hormone called egg recruiting hormone called FSH. But then you have got all this other side of the coin over here. You've got abnormalities in your liver. You have abnormalities in fat, in the way in which you utilize fat. And there tends to be insulin resistance with all this. So it's very complicated, and we're not even sure. There probably is an underlying genetic factor to all of this. So if I lowered your circulating androgens, I would not fix your insulin resistance. But if I lowered your insulin, I'd lower your circulating androgens. So that's what we realized about the year in the 80s and the 90s, is that women tend to be insulin resistant. But not everybody has insulin resistance. That's what's so confusing. At most, 25% of women will have some form of insulin resistance. So if you don't have insulin resistance, how do you have high circulating androgens? So there's probably subtle abnormalities in your insulin, the insulin pathway at the level of the muscle, the pancreas, the liver, that's ultimately leading to this. Because this is what you more often see, is this, and not everybody has this. But if I lower this, I don't fix this, but if I fix this, I lower that. Does that confuse you? Because it is still confusing. Yeah.
So as far as the genetic factors, I know you say that you don't really know. I had heard, or maybe I've just read, or maybe it just goes along with how I thought the metabolic syndrome. But I had heard that it's a gene that comes also from like diabetes. So like if a lot of family members or something has it, you're more likely to have PCOS, or at least that makes sense where it comes from.
Not necessarily PCOS, but diabetes. So there's a possible link. There's a thought process that it may be linked to a particular chromosome, but it has not been clearly established. So every disease that we have probably is genetic. But there may be something that's going on in utero. So if you're exposed to androgens, that androgen may cause a preset difference in the fetus that can predispose to PCOS. And so it's not always genetic. It may be something the mother's exposed to the child. But at the end of the day, what we do know is that there's increased androgens, that in up to a quarter of women there's clear insulin resistance, but we're unsure if it's a genetic factor.
I have PCOS, but my mom, she had PCOS, and my sister does not.
Mm-hmm.
So, and I have the insulin resistance. So I was really curious about that because I didn't understand why I ended up with that and my sister didn't. She's perfectly fine.
Part of it is that, like, if you look at why are 55% of women heavy, have extra weight, and the other half don't. And so part of it is that those women may have a genetic preset, the ones that are lean, that have that lean phenotype, that they may have a certain metabolism that's different, or they may be so inclined to overworking out that if they stopped working out, they may gain weight. So that's what's very confusing about it. There probably is a genetic link to it, but what I'm telling you is that it hasn't been linked to a specific gene. But what we can tell you is that it's insulin that's probably playing the story here. And this is what's interesting, is that you eat sugar, and you have all this high sugar, and so your body pumps out insulin, and it drives the sugar down. And you need sugar for energy, and it also has to be stored for states of starvation. So, between lunch and dinner, you're starving. So what happens is that unless you snack, what happens is that the liver breaks down the stored sugars, and it pumps it out so you can use it for energy. Okay, so that's kind of a starvation state for those 6 hours. Now, imagine it prolonged over a couple of days. So, but then what happens is that as you eat the sugar and you pump out all this insulin, the muscle and the liver doesn't go away, but it finds these receptors here and it drives the production of androgens. And that's what we know. That is absolutely what we know. It's strange is that she has insulin resistance. She's lean. You may not have insulin resistance, and your body mass index is a little bit bigger. So, and that's what's so strange about this disorder. That's why I say it's the Holy Grail, because we still haven't figured it all out. So that's where it presents with multiple different clinical manifestations. So some women present to me because they don't ovulate, and in order to have a period, you need two critical hormones. You need estrogen, and once you ovulate, you make progesterone. So the best way, or the easiest way for me to think about this is that estrogen is the building blocks in the uterus, and the progesterone is the mortar. So if you don't get pregnant, the ovaries take a couple days off, and you shed that lining off. But if women don't ovulate and make mortar or progesterone, you get this excess amounts of estrogen. You get it from your skin, you get it from your adrenal, you can get it from your ovaries, even without ovulating, and women can have breakthrough bleeding. They can have bleed and bleed and bleed and bleed because they're not making progesterone, they're not ovulating, they're not making mortar. So women can come in with bleeding issues. So some women will come in with excess amounts of androgens, and they have cosmetic issues. They have extra hair, the acne, the gland, the sebum from this gland is sitting right at the root of the hair follicle that sits right in here, and so they have acne problems. And then some women have weight-related issues, okay? And then if you don't ovulate, if you don't ovulate, you're not going to get pregnant. So there are many women that will have infertility-related issues. So when somebody comes into my office and says, I have PCOS, I go, okay, that's great. We're going to talk about that today. Why are you here? What's the number one thing that's important to you? And so that's where we focus the treatment plan for everybody, because the treatments are going to be a little bit different. Sometimes these overlap, but certainly for fertility, as opposed to this, they're very, very different. Okay, so what is the definition of hyperandrogenism? And that's where, you should use this when if cosmetic is really important to you, you should use this Fairman-Galloway score. There's actually not any other good way of assessing this other than a score, and you can monitor the treatment that whoever's treating you, and you can monitor this, and it's based on amount of hair on your upper lip, on your chin, your chest, your back. If you have what we call a male escutcheon, where the hair is going up here on your back, and again, if you have a score more than 8, that's defined as excess hair growth. Now, for some women, we always look for this. These are signs of acanthosis, where you can see hyperpigmentation in the creases, in the inner thighs, along here, under the armpits. That is a sign of insulin resistance. Now, one other thing, and I always say this, after I explain this, you're never going to look at people, you're going to look at people so differently after I explain this to you. When you look at guys, we are heavier here, okay? And we're heavier here because the androgens cause central fat deposition, okay? So when a woman is bigger here than she is here, that's actually better than if you are bigger here than you are there. And so we call that two different types of adiposity. This is a android, and this is a gynecoid obesity. And what happens is that androgens cause the fat deposition, and it's visceral. It's not just the belly here, but it's also intra-abdominal. And that excess intra-abdominal fat is associated with insulin resistance. And the body can't, this gets a little complicated. There's changes in adiponectin and the way we metabolize things. And so there's an increase in insulin resistance there, which then goes to the ovaries and causes androgen production and causes vascular disease and all those other things. But we tend to see this in women that are hyperandrogenic. This is the classic phenotype. that they tend to have central obesity essentially bigger than they are here. And so there's actually a greater risk of cardiovascular morbidity mortality. And we're not talking about today. This is really important. People who have PCOS are not at a greater risk of dying today. This is a long-term issue. The shorter-term issues are these: bleeding and acne. You get anemic. Nobody wants to bleed all the time. It's a cosmetic issue. This has dramatically affected quality of life issues, which I'll talk about in a little bit. Quality of life issues, there's greater depression, there's greater sexual dysfunction issues related to this that can easily be helped. And weight is a major issue that, unfortunately many physicians kind of just blow that off. But it's very, very important to a lot of people, and there's a lot of people that have major issues in getting it off, or at least stabilizing it. And I always tell people that it's unrealistic to think that you're going to get to ideal body weight. What's most important is that if you can get about 5% of your current body weight off, you're going to reduce risks of this, and you're going to dramatically increase your likelihood of getting pregnant. Now, for some people that don't have weight issues, they're an atypical phenotype. They're a typical physical presentation. They're not worried about that issue. That's not key to them. There may be these, or it may end up being a fertility issue. So I emphasize this again. This is really important. Your physician may say, oh, you have PCOS. Oh, yeah, irregular cycle, you have PCOS. And that's not true. It's a diagnosis of exclusion. So some simple things like thyroid disorders. Women can have abnormal bleeding, can have hair issues because they have abnormalities in thyroid. Thyroid can cause weight problems. There's a hormone called prolactin that's very important for breast milk production. That can cause irregular cycles. Women oftentimes will manifest with breast discharge, galactorrhea, but they may not. They may just present with irregular menstrual cycles. And then, of course, there's all of these other things. Like we have to, if you're virilizing, meaning you have male pattern baldness, if your clitoris is getting rapidly enlarged, that's virilization. That's very different than someone who's got mild signs of androgen excess. Okay, so these are things. Cushing's syndrome, you may have heard that. That's an adrenal disorder. Women who have Cushing's syndrome look very, very different than a woman who has PCOS. They tend to have blue striations on their belly. They have easy bruisability. They have a buffalo hump up over here. They tend to the hair that they have is very different. It's a vellus. It's a peach fuzz excess hair, as opposed to the coarse hair terminal follicles. So that's what we see with hirsutism or PCOS or virilizing tumors. So it's very, very important. You can't make a diagnosis of PCOS unless you exclude everything else. So now, again, I'm giving you a lecture here. You interrupt me, ask me questions. But in addition to that, not only do we exclude other things, but there's a clear workup. And there appears to be a whole bunch of things, but actually in a very simplified way, we do a free testosterone, simple. We do a TSH, we do a prolactin. And the most important thing, the debatable thing, is do we do glucose tolerance testing to see if you're diabetic? And that's a challenge because not every physician does that. And of course, if you're trying to get pregnant, then we have infertility diagnostic workup that we do as well. So when you see that patient that's coming in for cosmetic issues, you should be referring them to someone who's making sure they don't have any underlying metabolic disorders. So metabolic syndrome, what is it? Well, there it is. These are all the associated issues related to this. Heart disease, hypertension, again, those are long-term related issues. Some women can develop fatty liver disease where they have abnormalities in the liver. So it's important to do comprehensive metabolic panels. There's cancer. Cancer is a very, very underestimated issue that people don't think about. Breast cancer and also uterine cancers. So I want to make this really, really simple here. This is to have metabolic syndrome, you have to, and this is in your handout here, you have to have 3 of the 5. So in my office, I make everybody get waist circumferences, hip circumferences, and we look for HDL cholesterol, triglycerides, blood pressure, and we do an oral glucose tolerance test to rule out if somebody doesn't have metabolic syndrome. Okay, because metabolic syndrome is associated with all these bad things. That's long-term issues. And so these things potentially can be, we can fix them to help prevent them. The big question is that it's really important that your doctor's not doing anything wrong if they don't do sugar testing to make a diagnosis of PCOS. They don't have to do it to make the diagnosis. However, many of us still do it. I do it in all lean PCOS. I do it in overweight and obese PCOS women. And that's actually based on our international guidelines. But anybody who's overweight, obese, non-obese women should be considered if the following risk factors are there. If they have high blood pressure, if they have any signs of acanthosis, or if they have family members who have cardiovascular disease or have diabetes. Yes?
I started first showing symptoms when I was 13. I actually was obese. I reached up to 196 pounds.
Mm-hmm.
And only 3 years ago did that come off. Like, I know I lost 10 pounds in each month. I don't know exactly what could cause that, because I know with my PCOS symptoms, like that was one of the things that really targeted, because I could never lose weight. I couldn't do anything. Like, I was constantly running and doing all this stuff, and I still did not lose weight until my mom had a stroke 3 years ago, and I could stress caused
Mm-hmm.
that.
Mm-hmm. And did you have your thyroid checked?
I did. I had my thyroid, I had my blood sugar, I had everything, and they didn't diagnose me until I was 18. When they did an ultrasound, they did blood work. I had the abnormal hair growth. I basically had the majority of the symptoms already on the screen.
Mm-hmm.
So I didn't know if that could cause it just to switch.
It can. It could be, your metabolic usage, stress. Not so much the stress, but the way you metabolized energy consumption. Probably stress also affected your dietary intake, your caloric intake. So that may have had an impact as well. So it's a hard one to explain. It's a very frustrating one for women that are heavier.
Yeah.
So I think this is a good take-home fact here that women, you heard this lecture already, so this was a good segue. So for women that are obese, and we define that as a body mass index of greater than 30, and we calculate that based on your height and your weight, and body mass index, it's not perfect. So Arnold Schwarzenegger in his heyday had a BMI of over 40, but that's because he was so muscular. But generally, body mass index, heavier, more adiposity, and greater risk of metabolic disease. So it's a good correlator, but it's not perfect. In women that have a BMI that's more than 30, we define as obese PCOS women, about almost 40% will have impaired glucose tolerance, IGT. 10% will be frankly diabetic. Women that are lean PCOS women, about 2% are frankly diabetic, and somewhere between 5 to 10% of them will have impaired glucose tolerance. So it's important that just because you have a thin woman who has irregular cycles, I don't ignore evaluating for insulin sensitivity. I think this is really important because what's happened internationally is we've now defined what is PCOS, and based on how we define it affects the prevalence. Okay, so prevalence just means what percentage of people have it, have the disease or have the disorder. So classically, the diagnostic criteria in 1990, we all agreed that you had to have one of the two. Do you think you have PCOS?
I do have PCOS.
Okay, so this. Chronic anovulation means you don't have regular periods. That we use that. So you have to have both of these criteria. Okay, now I'm getting real personal, and you had to show signs of clinical or biochemical, meaning like testosterone, that's blood, that's biochemical, and you had to exclude other causes. So that's classically how we defined PCOS. You had to have both of these. So when you look at using this criteria, maybe somewhere between 5 to 10% of reproductive age women have PCOS. Well, in 2003, the Europeans, those doggone Europeans, said, you know what, I think we should add the inclusion of ultrasound. So you had to have 2 of the 3. You had to have irregular cycles. You had to have either clinical excess hair, or not everybody has excess hair, biochemical signs, testosterone, some elevated androgens. If you notice, there's nothing in here about insulin. There's nothing in here about insulin at all. And what they did is they threw in the PCO appearing ovaries. The problem is 25% of normal women have PCO appearing ovaries. And some women have one hair here. Their doctor may call them clinical androgen excess. They don't use Fairman-Galloway scores. That's excess androgen, so we may be overdiagnosing it. So the Androgen Excess Society that I'm a part of, we said that you also had to have 2 out of the 3, but most importantly, you had to have androgen excess. But not everybody, you didn't have to have irregular cycles, and you didn't have to have PCO appearing ovaries. So you had to have one of the 2. Okay? That still makes it nebulous. So which one do we use? Most people today, most doctors, most physicians use this one. For science, I use this when I'm doing research, because this is real strict. And in my patients clinically, I'll use this, because I scan everybody for ultrasound. Because this really, really cones down those people that have true PCOS. So this just, again, shows our definition of polycystic appearing ovaries. Sometimes we use the volume of the ovary. Sometimes we count the number of black circles that you see there. And you only need to have one ovary. Okay? Birth control pills may affect the numbers of those follicles. Okay, so you can have one ovary that is PCO and another one that's normal. You still get the definition of PCO, appearing ovaries. So the NIH criteria, and the only reason I'm showing this to you is just to understand is that some people are overdiagnosed with it. I'm not questioning whether you are or aren't. You clearly have, based on what you've said, and based on NIH criteria, you have PCO appearing ovaries. But you can see the prevalence using those strict criteria. And when we use the Rotterdam, look how high. That almost tells you at least 3/4 of women, 50 to 3/4 of women have PCO. And when we use the last one, where you can either have PCO or irregular cycles, the prevalence is somewhere in the middle. Now, why is that important? Because of pre-existing medical conditions, and you don't want to be excluded from getting health care. So it's just real important that definitely when there's a borderline thing, just don't use PCO-looking ovaries to make a diagnosis. Impaired glucose tolerance, IGT, or diabetes, you can see that PCO women are more likely to have insulin resistance. And you can see there's a 2 times greater likelihood of progressing to impaired glucose tolerance every year. So even if you have normal sugars today, that prevalence goes up twofold every year if you have PCOS. So now, I'm going to keep going here, but are there any questions so far? Yes?
As far as you saying that it goes up each year, now is that still going to go up, even like, assuming you're overweight, but if you watch what you're eating?
It's a very good question, because there was a national product. It's a project. It was called the Diabetes Prevention, the DDP program, And what they found is that the best treatment to prevent diabetes was exercise and weight loss. So no, for most people who are not avid exercisers. They're just not. They're sedentary. They're going to stay home. They're not going to get up and move. It's for those people that prevalence goes up that high.
Even if you don't necessarily lose weight?
Right.
You're exercising?
Yeah. No, yeah. Oh, exercise is the key for preventing diabetes. You make yourself more insulin sensitive. Did you have a question?
Yes. Curious whether anything in your testing has ever involved the inflammation, like the monitors for inflammation or the rates of inflammation.
It's not standard for us to look at like things like C-reactive protein, homocysteine, things like that look at vascular risk. That's not.
Wouldn't it be a possibility to look at that because an inflammation could be caused from the way the possible metabolizing food allergies, digestion?
It's not standard in the way we evaluate, but I think when patients have like blood clot histories, then that becomes more likely that we're going to evaluate that. But I mean, it's a good question, but it's not standard in evaluating for women that have polycystic ovarian syndrome. It's not part. What I'm saying is, it's not part of the routine for us to do that.
At which point in a woman's life you would find that this is definitely the right diagnosis? Can it happen that?
No, what's so challenging about this is that as a young woman, this is like a progressive lifelong disorder. As women in their adolescent years, they're transitioning, and what happens is the brain starts talking to the ovaries. And actually, we call that maturing of the hypothalamic pituitary ovarian axis. And it actually matures at night, during sleep, during REM sleep. So for those people that, when you're raising your kids and your daughters are sleeping, your boys are sleeping, let them sleep because their hypothalamic pituitary gonadoaxis is maturing while they're sleeping. So if you wake it up, you may mess it up. But that's actually the truth, though. They need to sleep. But many of those people, many of those girls, will have abnormal menstrual cycles during their adolescent years and have acne, and then it goes away as that hypothalamic pituitary axis matures. But in some women, it'll continue to progress. And sometimes we don't see its onset until the reproductive age women. And then a fascinating topic is what happens when a PCO woman gets into menopause, and now that her ovaries aren't making androgens anymore, what ultimately happens to her? And so there's still a lot of research that's going on in the advanced reproductive age woman who's had PCO and now is menopausal, where she doesn't have those multiple follicles anymore. So we can see it present at any time, but you got to be real careful in that adolescent in labeling her, because it may be an immature hypothalamic pituitary axis.
And that typically happens around 22.
Well, in a young adolescent, we can start seeing acne and hair and irregular cycles at 13, 14 years of age. But you may see signs of hair abnormalities, even in their teens. So I try to get on them real early and try to regulate their cycles and reduce the amount of circulating androgens that they have.
And that happens that those young women would be on birth control to regulate the cycle, while maybe this is actually a very important symptom, something more important than just not being.
Actually, one of the treatments is birth control. And oh yeah, absolutely, because what it does is it regulates, it reduces the amount of circulating androgens by the ovary, and it also prevents the androgens from binding to the hair follicle, and it reduces the terminal hair follicles, these coarse hair follicles. The challenges that we have is that when I have a mother and a father that come in, and I'm talking to a 15-year-old female, and I have to use the words real carefully. I don't say birth control pills. I have to say, we have these hormonal manipulation medications. I mean, like I have to pick and choose the words that I say, and and then after they go, oh wow, that's great, and I go, but sometimes we call them birth control pills, and the reaction that I get is like, my daughter is she's not a promiscuous human being. I mean, like, and it's unbelievable. And I tell them, listen, let's put her on this. It's going to regulate it. She's not going to get anemic. She's not going to be hemorrhaging. She can know when she gets her periods. Was it that funny? No, yeah. CPR? You okay?
You went down the wrong too, sorry.
Actually, I'll give them a trial coming off after maybe a year or two, because in those girls, the hypothalamic pituitary may be maturing at that point, and then I can give a trial coming off of it. But it's actually a challenge. Yeah, the adolescent females don't have any issues going on at all. For many reasons. Most importantly is that if they can regulate their acne and have some normal semblance of life with periods, they're happy. But it's generally the mothers that are really opposed to them doing it. So I have to use magical words like, hormonal manipulation medications, So now, the other things that I did mention is that endometrial cancer is a big issue. We can see that in the young reproductive age woman. You okay?
Yeah, sorry.
Okay. Sure. Mm-hmm. No, actually, no. That's wrong.
I mean,
Mm-hmm. No, I mean, I can explain that in a couple of slides here, but no, it will regulate. And there's actually different types of birth control. You just have to be really careful. So many physicians are used to using birth control X, and they don't realize that the type of birth control that they're using actually has androgenic side effects. So hair. Oh, let me just finish this one thought. So hair, and you actually want to use a very low dose formulation for women that don't have androgenic side effects, because the progesterone in the birth control is actually derived from androgens. So if you use a very strong progesterone, it can have androgenic side effects. So you have to be very, very careful. So you're kind of right, but yet you're kind of wrong. So or your doctors that you're telling you were wrong. Okay, does that make sense?
That clears up a lot.
Okay.
I had a doctor, honestly, she didn't know much about PCOS because she just gave me birth control like right off the spot. Like, she didn't really check the levels or anything, the hormones, and it actually caused side effects with me. I had been on like 7 different types of birth control until I finally got a gynecologist who knew more about PCOS and finally had like me on a more regular level. But it's really, I can't stress enough, you want to definitely make sure that it's the right type of birth control, because it can have really negative side effects to it.
There are some of the more potent birth control pills we want to use. They have they're stronger progestins, stronger androgen derivatives, because women that have heavy bleeding, I want to use those for the abnormal uterine bleeders. But because they have androgenic side effects, they're going to get acne, they're going to get hair, they may get weight gain, and that's not a good pill to use in the woman who's got cosmetic related issues and not bleeding related issues. So what's important in women that don't ovulate, anovulators, remember I told you need progesterone to stop the growth of the lining. So women that don't ovulate, you don't make progesterone, you're not going to get a period. And so what can happen is that whole lining builds up and builds up and builds up, and what happens here is you get this buildup here, and that's what can lead to precancerous and cancerous lesions. So women that are at greatest risk for that in reproductive age women who have less than 2 periods a year. So I always tell women, you don't have to have a period every month. You don't have to have a period every three months. Just make sure you have at least 2 periods a year by putting you on regular progesterone to shed off the lining of the uterus. Ideally, some women, that's me, I would prefer to have a period every month. There's something that's very reassuring about that. And there's some women that just don't want periods, and that's okay. So you just have to magically figure out what it is that they want. The other is that there is an association with mood disturbances, quality of life, sexual dysfunction, depression, suicide. Some of that may be vitamin D deficiency. Some of it may just be underlying that we're not sure if it's the all of the myriad of symptoms are leading to psychological issues, or whether it's the psychological issues that are leading to all of these other elements, so they're all interrelated. But in all patients with PCO, I check all vitamin D levels. Actually, one of our clinical trials that we're doing is looking at vitamin D and birth control and assessing sexual dysfunction, specifically sexual dysfunction, and we're trying to separate sexual dysfunction from depression because there's a significantly higher mild, moderate, and severe depression in women that have polycystic ovarian syndrome. So very, very important. Now, the treatments, again, it all comes down to, when you come in to talk to me about PCOS, you get this, right, Heidi? They get this discussion. They get this long discussion about why do you have it, what does it have, what does it mean, what can it cause to you? Now tell me what it is that you want me to fix. Because I can't fix all of them today, and I can't do fertility if you want me to fix your bleeding problems. So, you know, I let patients help me help them. So, so if we just focus on the first issue, which is bleeding disorders, the standard of care is hormonal contraception. Is hormonal, is combined low dose, and I think we beat this to a dead horse, is that it's the type of birth control that you're going to use. You can use progestin only. There are some women that have PCOS that have an increase in vascular abnormalities, that have clots, history of DVTs, that can use progestin only. So we can make sure they have regular periods, but we can use that to try to lower the androgens, try to get them to have regular periods as well. Now, does anybody know anything about insulin sensitizing agents? That's lowering circulating insulin, like metformin, glucophage. Some have tried using metformin to regulate menstrual cycles, but it is not FDA approved. It's just important to know that. Metformin is an insulin sensitizing agent. So it allows the cells to respond to your circulating insulin that will allow you to take up the blood sugar and get it out of the bloodstream. And as a result, you don't keep pumping out tons of insulin, and therefore that goes to the ovary and causes excess androgen production. Okay? So there's a number of different insulin sensitizing agents, but the primary one in my line of work is metformin. So how about hair or hirsutism? So how effective are treatments in treating women with PCOS? Well, they actually are fairly effective, but let's just talk about hair follicles. This looks like it's a lot. I probably should have just made this image bigger here. This is what a hair follicle looks like. Okay, it's got a root that's surrounded by a glandular structure, and then it comes out of the skin, and that root-like structure starts off in a building phase, a resting phase, and then a destruction phase. So anagen, telogen, and catagen. And actually the half-life, not the half-life, the life of a hair follicle is anywhere between 4 to 6 months. Now, you and I were born with a finite number of hair follicles. There's a lot of them, but we're born. We don't keep making them. That hair follicle eventually dies, and it falls out. You wash your hair, and it falls out. Okay, right? You're in the shower, you notice there's hair there. Well, that was in the breakdown phase, the catagen phase. But if all of our hair follicles were in the same phase, I have to point at you, we'd be looking like you, okay? They'd all be falling out. But, you know, women that get pregnant and deliver a baby, they all of a sudden, have you ever heard, hey, you know, I've lost patches of hair? Well, pregnancy actually moves all the hair follicles into the same phase. So that's why women, after they're delivering babies, tend to lose large patches of hair. But it goes through this cycling phase here. And hair is primarily stimulated. And the reason that's important is that this hair follicle came out today, and so it's going to fall out when? 6 months from now. And this hair follicle that comes out 3 weeks from now is going to fall out 6 months plus 3 weeks later. So you can't treat it all at once, and it takes a long period of time, and patients need to understand that when you're treating it. Does that make sense? So now, what's important is that the liver makes this chemical. I call them U-hauls. It makes this U-haul. It travels around the whole body. And if you have a lot of those U-hauls, that will just drive right by the hair follicle. So some of our treatments are to increase the liver to make those U-hauls. It's actually birth control pills do that. The other is to prevent the androgen from binding to the receptor. So the androgen gets off the U-haul, binds on here, and causes that peach fuzz to turn into that dark, coarse hair follicle. But what happens when androgens, testosterone binds to this, it's turned into the most potent androgen in the body, which is called dihydrotestosterone. So with that knowledge, we can utilize different medications to help patients with cosmetic-related issues. So we can either reduce ovarian androgen production, we can increase the transport hormones, we can block the receptor, or I can prevent that androgen that binds to the receptor to turn into the most potent androgen. So it depends on what you want. It depends on side effect profiles, and there may be some women that have taken spironolactone, and that's what you're doing is you're preventing that androgen from binding to the receptor. Birth control pills are great because they increase the transport, they reduce ovarian androgen production. So it depends on what you want, and you can tailor the treatment, but it's important to know that it's going to take at least 4 to 6 months of monitoring that Fermin-Galloway score that you're going to actually see an improvement. You almost see an immediate improvement in acne. Okay? Now, for this woman over here who's the esthetician, the best treatment, it's okay if you shave. It's okay if you pluck. Just have to be careful. It's clean. Hold on a second. It's very important that you want to make sure it's clean so you don't get a folliculitis. But the best treatment is laser vaporization. And the reason that's the best is that there's melanin in the hair follicle, and it absorbs the ultraviolet light, and therefore it will destroy the hair follicle. So it is more expensive than waxing, but it is probably the most effective in terms of cosmetic, immediate cosmetic effects, in addition to using medical therapies. There's also another medicine, I don't know if anybody has used it, that the hair follicle is also growing as it comes out, and if you can slow that metabolism down, there's a topical gel that we use. It's called Vaniqua, and so you can use it indefinitely, although not every woman. You'll see probably about a 40 to 50% improvement using that medication. So in conjunction with lowering ovarian androgens, some type of mechanical means of removing the hair, there's ways of significantly making it a lot better for women. Okay, what about the treatment of obesity? Well, here's what the current recommendations are. So if you can lose 20 pounds, your current body weight, you will have a 25% reduction in overall cause of cardiovascular morbidity, mortality, and cancer mortality. 20 pounds, okay? Not down to ideal body weight. And 5 to 10% of your current body weight will improve fertility treatment. And for morbidly obese patients, there's a 50% reduction in treatment. Now, I would argue, my God, let's come up with a game plan, because I don't want you to spend money knowing that I may impact your ability, we're already starting with a compromised ability to get you pregnant. Now, some people would say they wouldn't treat you. I don't do that. I want to work with you, make sure you don't have insulin resistance before you get pregnant, but it's not something to discard. It's very, very important. So there's ways, I'm not going to go through these medications. These are clomiphene citrate or oral medications that trick your brain into making egg recruiting hormone. About 3/4 of women will ovulate. and probably about 50% will conceive on very, very low doses. Now, for some women that don't respond to the Clomid, because not everybody does, I can actually give you FSH or egg recruiting hormone through an injection of what are called gonadotropins. Okay, so these gonadotropins are purified of their injectables, and I just want to show you what it does to a PCO-looking ovary, is that it can cause the recruitment of multiple eggs. And so if it causes multiple eggs, it can cause multiple babies. So we try really hard to avoid that. Okay, because PCO women are very, very sensitive to infertility medications. You have to be very careful. And I would tell you, if you have a very difficult case of PCO and you have infertility-related issues, I wouldn't have your generalist. I'd see a specialist, kind of like me, but just a specialist, okay? But it's very important because you can get not only very pregnant, but you can get very sick. This is just a picture of ovarian drilling. Looks morbid, no? Okay, this is done through the belly button, and we just make these small little hole punctures in the ovary. The thing is, we reserve it as a secondary line of therapy because now you have a raw surface there, and it may cause pelvic adhesions. So we want to try to avoid that if we can. So again, a number of different options that we have, and I'm going to just open it up for questions here because it's not always so straightforward. Sometimes, like in a patient like this, she doesn't want to go on birth control pills because she gains weight. This is a challenge, but she's got irregular cycles and she's complaining of androgen excess, but doesn't want to go on pills because she gains weight. So what do we do? Or in a patient like this who's got insulin resistance and she's got underlying kidney disease. That's her creatinine and thought to be related to the cyclosporin. And now the question is she can't go on insulin sensitizing agents. What do you put her on? So these are some of the subtle challenges that we can have related to this disorder. Or in a patient like this who doesn't have insulin resistance but has a strong family history of diabetes and wants to know if metformin is going to help her with weight loss. It'll help with diarrhea. She's going to have diarrhea, so I don't know if that's going to cause weight loss. But question is, what do we recommend? And then sometimes we have women that have PCOS who don't ovulate, and they go, well, should we take eggs out of the body called IVF? And the answer to that is no. We can treat it very, very simply with most of the time oral medications, and it's really simple to treat those infertile women. So I didn't really want to, I really struggled in putting this together because I didn't want to make it lecture format, but I couldn't come up with a simpler way to have an open dialogue and talk about PCO without having visuals. So I hope you hope you learned something. So do you have questions now? You can ask me anything you want.
I was wondering, in regards to the clinical trials, how would that work?
Prefer doing a clinical trial? Well, just so you know, there's a handout in there, and actually I don't just do PCO work. There's a phone number of, my cell phone number is directly in there. We have other clinical trials that we're doing. We do fibroid work. We do chronic pelvic pain work. PCO, the PCO study, you can just contact, I think it's the second one. Yep, that's that one. Those are our clinical trials that we're currently doing here. So you just contact me and we can help you get enrolled into it. There are requirements to get involved in the study, or sometimes you have to be off medications for a month before enrolling into the study. Okay? And actually, some of the studies actually pay you. That's actually a bonus. Doesn't pay me, but it pays you. Okay? Actually, the PCO study was a study that I secured and came up with the idea, and is funded by the Patty Brisbane Foundation down in Cincinnati, who's very big into sexual health, and so they're funding that clinical trial. But some of the other studies are industry-sponsored studies.
If I may ask, who those trials involve? What is the approach with the trial?
It depends on could you be specific about the type of trial? With which study? In that particular study, it's actually pretty simple. In that study, you have to be off of any type of hormonal manipulation for a month ahead of time. And then what you do is you come in and you're going to take a Beck Inventory Depression Scale. So it's set up a standardized test. And because many people have some form of depression, as long as you don't have severe depression, which is associated with suicidal potential possibilities, that you would be a candidate for enrollment. Then what you do is we're going to be assessing the prevalence of sexual dysfunction, so women will be taking a sexual dysfunction questionnaire. Then what they do is they then go on vitamin D. Vitamin D has been thought to help with a lot of reproductive dysfunction issues, and women will also get the option of either using hormonal contraception, what's the word I should use? Hormonal manipulation medication, therapy, or if they don't want to use hormonal manipulation, contraception, they have to use some barrier contraception. So we supply the vitamin D, we supply the birth control, we supply the Beck inventory, the sexual dysfunction, and then you go on it for 6 months, and we see you back. We see you at 3 months, we see you back at 6 months, just to check blood pressure at 3 months, and then we give you another 3-month supply, and then you redo the sexual dysfunction questionnaire, which is really like 25 questions. It's not very long. So that's the clinical trial, and we're looking to see the prevalence of sexual dysfunction, and we're looking to see the impact of both vitamin D and/or hormonal contraception with regards to sexual satisfaction or dysfunction.
How high is the dose of the vitamin D?
It's the FDA regulated dose of 600 international units a day.
What is the level you're trying to get the vitamin D blood serum?
I apologize?
What is the blood serum level for vitamin D you're trying to?
We're actually going to be blinded to what the vitamin D level is. We're not going to look at it at all. So women can have normal vitamin D and then go on vitamin D, or they could have low vitamin. So we want to see that. It would be nice to see that women that had low vitamin D were more likely to have sexual dysfunction. We put them on it and they get better. Or women may not have any improvement because their vitamin D was normal. So maybe we're able to attribute it to vitamin D levels or not. So we're going to be blinded to what that actual value is.
So who would be the ideal candidate for this study?
Anybody who has PCOS who does not want to get pregnant for 6 months. That's the ideal candidate. Yes, ma'am. Oh, okay. There's a phone number in there. You can give me a shot. Give me a shout if you would like. Okay? Yes, ma'am.
Now, like levothyroxine, you'd still be able to take that, or is that going to count as?
Which medication?
Levothyroxine is for the
Oh, yeah.
thyroid.
Yeah.
So that would still be.
That's okay. That wouldn't exclude.
What if you already take vitamin D?
You have to come off the vitamin D. And then you're going to go back on the vitamin D. Everybody goes on vitamin D.
I'm on much higher than 600. So.
Yeah, I know. There's people that are using 50,000 units a day, but I'm not a super advocate of that. So, but yeah, you'd have to come off it for a month.
You're already on birth control. You wouldn't be off of it for a month after.
Just be off it for a month, and then go back on it, if that's what you elect to do. Ladies behind you, did you learn anything? Okay. Ma'am?
Yeah.
Okay.
If you want to describe your PCOS to someone, what is the best way to describe them, like what you have? Because I've tried to describe what I have to people and they don't fully understand it at all.
The best way to describe it is using the criteria based on Rotterdam, or you use the NIH criteria. You say, I have irregular cycles, which typically we define as less than 21 days and more than 35 days. So you can have polymenorrhea or you can have oligomenorrhea, frequent or infrequent. So I have irregular cycles because 28 days is, everybody's different than that. So 21 to 35. And I have clinical signs of androgen excess. Now, you may say I have irregular cycles, and you may not have clinical signs of this, but your doctor should be drawing androgens in your blood, and you'd say, I have biochemical signs of androgen excess. So, because again, like the Scandinavian population, the Asian population may not exhibit it like a different European-based person. That's how you would describe it. Now, I didn't use the word insulin resistance because you don't have to have it. And that, and they ruled out that I don't have thyroid and I don't have prolactin problems. I don't have anything else. Remember, it's a diagnosis of exclusion. Sir, you have any question? Nothing?
One more question about the treatment with particularly making the more invasive treatment where you mentioned that they were actually shaving portion of the ovary. Why did they notice such a big difference?
It's a good question. Because if we believe that it was anatomic, that the egg couldn't get out of that thickened shell, people started ovulating on it. When we started doing this in the 80s, where we were puncturing holes in the ovary, less invasive than taking a wedge of the ovary out, people started ovulating. However, it reversed. It didn't stay normal forever. So, if you go all the way back to my first slide with that cup, that little cup there, that cup is the Holy Grail. We don't know. We know it's probably insulin, but that's not the whole story because not everybody has high insulin levels. Okay? Does that make sense?
Yes. Is there a risk of permanently damaging the ovary with the laparoscopic treatment?
No. Not at all. Not at all. It's very simple. It's just a little laser that we pop a small little hole into it, and we always try to put it on the bottom side of the ovary that sits right next to your pelvic sidewall, so bowel won't sit on it and cause scarring. So we always try to put it on the underside of the ovary. And we put in about 10 small little puncture holes in the ovary.
And the amount of the punctures makes a difference as well?
I think that's just a historical reference that all of us have used.
And there was also a question about the 25% of lower risk with reducing the weight, approximately 20 pounds. Does the start weight make the difference in the growth?
No, because what you see is that if you look at the data, that women that have a BMI that if you look here, natural conception declines by 4% per kilogram when somebody who's above a BMI of 29. Okay? That's, if you look here, the relative risk, 1.3, is a 30% risk of infertility when you have a BMI between 25 and 31. And you have a 117% risk of infertility of BMI of 32. So whether you're 32 or you're 34 or you're 38, I would tell you that your threshold is probably somewhere between 30 and 32, but 26 versus 38, you're still at that same at a higher risk of baseline, and that's where you want to start from.
And the high cholesterol level, which was mentioned in the process, is that also in some way related?
That hasn't been shown. I think that the risk of infertility is associated with actually insulin resistance. So if you're already starting out diabetic before you try to get pregnant, you're going to have a harder time. So it's the insulin picture, not the cholesterol. And actually, we don't treat high cholesterol levels during pregnancy. We leave them alone.
Right. The question is if the body really is ready for pregnancy at that point, because we, of course, want to make sure
true, but let me just point out, let me give you another piece of information. We published a paper about a year and a half ago that looked at women who were gestational carriers. Okay? So we took your embryo and we gave it to someone else with a body mass index that was over 30. There was no adverse effect. And gestational carriers are generally fertile women who have had babies before. So it goes to show you that it's not always about weight. Maybe it's weight and irregular menstrual cycles or insulin resistance. So a lot of women do really, really well with pregnancy and elevated weights. So it's like you see here, anovulatory infertility. Women who have irregular cycles, who have a higher BMI, have a greater issue. So it's sort of, it's not just one issue. It's a accumulation of a bunch of factors. Any other questions? If you have private questions, I'll hang here. I think my cards are in there. You can contact me, and I appreciate your time. And I hope this didn't come across too much of a lecture, but it's definitely hard to have an informal dialogue in something that's kind of complicated. All right. I hope I had a positive impact somewhere. Make sure if you don't see me, you go see your doctor and you demand to have this done. Okay? You want an evaluation.